Hi guys, welcome back. The next topic we're studying is infective endocarditis, and I shall now be explaining to you organism-specific approach for this particular topic. Most of the time, they will ask you organisms responsible for acute bacterial endocarditis. Before answering it, do take care of the fact that whether he's asking you regarding community-acquired or hospital-acquired. You see, if I'm going to talk about a hospital-acquired acute bacterial endocarditis, it basically implies that the person was having maybe a central line in place, and therefore from the hospital environment, he can definitely get infection from Staph aureus. Now, this is obviously straightforward, but if it's going to be community-acquired, then the answer should be given as Streptococcus per se. The second aspect I want you to remember is organism for subacute bacterial endocarditis. That's going to be Streptococcus viridans. I know the fact that you are aware of this from the microbiology domain, but I just want to highlight an aspect which will definitely be a little contradictory maybe to what you have studied in microbiology, and I want to bring it to the forte. You see, when it comes to right-sided endocarditis, we are talking about an IV drug abuser who's obviously not going to follow any sense of hygiene, and therefore the infection will go into the right side of the heart, destroy the tricuspid valve. The organism in this case would be options between Staph aureus versus Staph epidermis, or he can write Coagulase negative Staphylococcus. What I have seen is a lot of guys casually answering Staphylococcus epidermis, whereas actually it is Staphylococcus aureus. Now I come to the aspect where I think that usually the queries can arise. That's going to be a question based on organism responsible for prostatic valve endocarditis. You see, when you read the textbook, he will talk about infection that will occur in the first 60 days after surgery. Then can be 2 to 12 months. Then he can definitely mention about after 12 months as well. After 12 months is not the controversy. That is pretty straightforward. Same as what I'm going to say, saying what the microbiologist is going to say, that is Streptococcus viridans. Complications, or I would say rather controversy, would arise with respect to the initial data that I'm now highlighting, because what I've come across from queries of a lot of students is that in some subjects or some apps it is given as Staph aureus, and well, I have taught Coagulase negative Staphylococcus. To supplement why I have said Coagulase negative Staphylococcus, what I'm going to do is just go back and show you a table from Harrison. Once I just zoom it in, you definitely can notice that he's mentioning regarding prostatic valve endocarditis here. And you can see that the highest percentage for the table with respect to prostatic valve endocarditis in the first 2 months, I'll highlight that again, first 2 months and 2 to 12 months, as highlighted is Coagulase negative Staphylococcus. Later on is no problem, that I said is Streptococcus viridans, but I've just shown this table to give credibility to the fact that this data that I've highlighted is supplemented by the table of Harrison. So I would definitely like you to remember, in lot of MCQs, instead of writing the word first 60 days or within first 2 months, he might write the word early onset prostatic valve endocarditis, or a late onset. Late would obviously mean after 1 year or so. I'm now going to describe a IV drug user once again, but in this person, there's going to be a slight difference with respect to the fact that there is a window open in the interatrial septum, which will allow everything that is coming in the right side of the heart to actually move to the left atria as well. You see, what I'm saying is that this guy is a IV drug user, and obviously the hygiene part will definitely be compromised. So in this particular chap, when the infection will come in the right side of the heart, there's a distinct possibility that via this window, the infection will go to the left side of the heart and will damage the mitral valve as well. The topic that I'm raising right now is called as left-sided endocarditis. The scenario is still of a IV drug user, but then the point is that after all, there's going to be damage to the left side of the heart. So he might ask you that which structural lesion is present here. Now, I have seen a lot of guys casually answering this as AST, that is atrial septal defect, but you are very well familiar with about the fact that AST will operate from left to right, whereas this is operating from right to left. So, well, what is present here is the first question that is asked. That would be PFO, that is a patent foraminal veil. And second, once the infection will go to the left side, it will obviously cause damage. So we need to understand organism-specific approach. Here again, some disparity can occur. But what I'm saying is that in an IV drug user, the right-sided endocarditis is going to be caused by Staph aureus. Then left-sided will also be Staph aureus. And if Staph aureus is not in the options, because it's obviously easy, the moment he will write IV drug user, left-sided endocarditis, I mean, just by reading this word, no IV drug user, you can very well come to the conclusion that Staph aureus should be given the first answer. So if Staph aureus is not in the options, then Enterococcus would be given. These are a couple of organism-specific approach that I've highlighted before you, and this is taught in other subjects also, but I opened up with this particular part just to sensitize you to the fact that lots of time they can obviously in integrated questions mix up the two informations. Now I will describe to you what is going to happen with respect to native valve endocarditis. And he might even ask you that which of the four valves of the heart, the options would be mitral, tricuspid, aortic, pulmonic, will be having highest chances of getting infected. You see, the logic behind this would be that mitral valve in our body operates at the highest hemodynamic stress. You will notice that mitral valve is invariably involved in all cardiac conditions, whether it be rheumatic heart disease, whether it be infective endocarditis, dilated cardiomyopathy. I mean, whenever there is stress on the heart, the first valve that will obviously be suffering, the first one to suffer will be mitral valve because it operates at the highest hemodynamic stress. Based on this, he might even give you valvular lesions like mitral regurgitation, mitral stenosis, aortic stenosis, aortic regurgitation, and might ask you that which of the following will be having a highest chance or highest incidence of development of infective endocarditis. To solve such a question, you need to just go by mathematics. Whichever of these valves will be operating at the highest pressure gradient and whichever valvular lesion will be operating at the highest valvular gradient, that is the one that is going to be most vulnerable. You see, I have deliberately given all the four options of the left side of the heart. It would have been an easier question if two options were from the right side, because they can obviously be excluded because right side of the heart operates at a lower pressure gradient. Now, when it comes to mitral regurgitation, the blood will be leaking during the phase of systole because mitral regurgitation, the gradient is dependent on the pressure difference between LV and LA. But mitral stenosis operates during the phase of diastole. So mitral stenosis I'm ruling out because obviously the pressure gradient will be relatively less. So is the case of valvular aortic stenosis. When it will operate, it will be operating at the pressure difference between the left ventricle and the aorta, and most patients of aortic stenosis have concentric left ventricular hypertrophy, so that is why the blood is able to go out of the heart. So what I'm saying is, out of the four lesions that I've highlighted before you, when it comes to aortic regurgitation, it will obviously be operating in diastole. So two options can be easily ruled out. Aortic regurgitation and mitral stenosis are off the radar. Why? Because diastole is a low pressure circulation. It's going to be either MR as answer or aortic stenosis. Now, what is going to be the answer here will depend on mathematics. Let us take the left ventricular pressure to be maybe 125, 130 because of the hypertrophy of the left side, and aorta pressure to be 120. So pressure difference will be like 130 minus 120, 10 millimeter of mercury. But look at the huge mathematical difference in the value of pressure of left ventricle and the left atria. I want you to understand the fact that mitral regurgitation will be having the highest incidence of development of infective endocarditis. As I highlighted, the logic behind this question is whichever valvular lesion. Now, I'm not saying valve. Obviously, mitral valve operates at the higher pressure gradient. Whichever valvular lesion will operate at the highest pressure gradient is the one which will be vulnerable per se for infective endocarditis. The query of lots of doctors is that, sir, why not? Answer is aortic stenosis. You can see for yourself, no, the pressure gradient in aortic stenosis, left ventricular pressure will be like 130. Okay, maybe increase it to 140 because of concentric left ventricular hypertrophy. Aortic pressure is going to be 120. Difference is only 20 millimeter of mercury, but the pressure difference between LV and LA is mathematically very huge. So I just want to highlight that here mathematics will be useful for evaluating the question. And based on the same explanation that I given you, if he says which condition of the heart overall, like it could be congenital heart disease, it's also given. If he says which of the following congenital heart diseases, or he says which heart condition per se will be having least incidence of infective endocarditis, then the answer should be given as atrial septal defect. Why? Because ASD operates at the least pressure gradient. The pressure difference between per se left atria and left ventricle is only 4 millimeter of mercury. If the pressure difference is going to be so less, then the chances of infection will be relatively reduced. Now, on the basis of this baseline information, now let us see what is actually going to happen in the patient. So let us assume this to be the left ventricle. These are the mitral valve leaflets that I have highlighted, and then I'll show the aorta as well as the colonization of the valve leaflets. Well, this is what I'm saying, guys. The bad news is there is vegetations which are growing on the surface of the heart valve, and because of these vegetations on the surface of the heart valve, therefore any of these vegetations can actually break off from here also, and they can go into systemic circulation. So heart has literally become the source of pumping bacteria into systemic circulation. This is what I said, some of these vegetations might break off from here and they are being thrown into distal circulation. So this person can even have brain abscess formation. He might be having rather a splenic abscess formation. In fact, the person can even die because of sepsis, because the heart has become the source of infection into the systemic circulation. The red lines that are drawn here basically represent the vegetations, and there is going to be two things present here. One is going to be fibrin and second is bacteria, and it's going to be like millions and trillions and mega trillions of bacteria which are going to systemic circulation, and that is what I opened up in this discussion also. The opening diagram, you can see these vegetations which are growing on the surface of the heart. Well, these are like small vaulty vegetations and they can definitely embolize into the systemic circulation. Now let us see, once they go into the systemic circulation, what will be the impact on the patient, though I've already sensitized you to the fact that there would be a septic process going on. Because of this embolization of vegetations, lots of clinical findings will also develop that we are going to study under the heading of modified Duke's criteria, which is useful for diagnosis of infective endocarditis. Lots of time in the MCQ, he might actually write this finding of splenomegaly in infective endocarditis. As I sensitized you, the reason for splenomegaly will be rather a splenic abscess developing in this patient. The heart has pumped this into systemic circulation. Don't be surprised if you read the word hemiplegia written in an MCQ of infective endocarditis. Well, these two that I'm writing before you are complications that can be developing in this particular patient, since there's going to be embolization of infection into the systemic circulation. Apart from this, even clubbing can develop. Now, clubbing is what we traditionally associated with cyanotic heart disease, or maybe we associate that with lung cancer, lung conditions like lung abscess, bronchiectasis. But clubbing will also be noticed in patients who are suffering from subacute variety of bacterial endocarditis. Mark my words there. Clubbing is not going to be present in acute bacterial endocarditis. Why? Because in acute bacterial endocarditis, the disease process can be so fulminant that the disease is going to develop so fast that, let me say, in 2 weeks, you are not going to have clubbing. Clubbing takes obviously a longer duration, maybe up to maybe few months or maybe up to 6 months to develop. So my point is, clubbing is definitely a feature of infective endocarditis, but which variety? The answer is subacute variety. In acute variety, because the disease is going to progress very fast, clubbing will not get time to develop. What I have highlighted here before you is proliferation of tissues at the base of the nail. You are anyway aware of the fact that the cytokine involved in causing of clubbing and proliferation of tissues at the base of the nail is PDGF, that is platelet-derived growth factor, and I have highlighted here the characteristic parrot beak appearance. And even in the later part of the disease, you might even be having periosteitis, and you might be having even the swelling of the terminal phalanx. So you might read the word hypertrophic pulmonary osteoarthropathy. Now the message here is that these points that I've written, splenomegaly / brain abscess / hemiplegia, clubbing, they're all complications. They're not diagnostic criteria. They would develop in those patients where the treatment has not been initiated on time. If you diagnose this condition early or on time, obviously the chances of these complications will be relatively lesser. But still, in some parts of India where medical care is even, I would say at a very primitive level, there's a distinct possibility that if the person is not diagnosed on time or is not treated, then this infection can go deeper. And what I've now shown is that there is a valve abscess. If there is a valve abscess, then God help this patient, because now there is going to be pus in the tissue of the valve and no antibiotic is going to reach here, because antibiotic reaches those areas where there's a blood supply. The tissues of the valve per se do not have any blood supply. Therefore, if you have a valve abscess, then you have a ring abscess, and as the area, this destruction process will keep on increasing, it is no big deal that in this same patient, after maybe a few days, the infective process, the septic process will eat away into the tissue of the valve. What I'm saying is extreme. The bacteria have literally punched a hole in the valve leaflet, and therefore the bad news is that now the pressure of the aorta can leak back into the left ventricle, and because of this perforation which is created in the valve leaflet, there would be a special finding that will lots of time be written in MCQs of infective endocarditis, that is new onset murmur. The reason for murmur is the perforation which will cause leakage of blood from the aorta back into the left ventricular chamber. He will say new onset murmur in a patient of pre-existing, I repeat the fact once again, new onset murmur in a patient of pre-existing heart disease. The examples of pre-existing heart disease could be like rheumatic heart disease or dilated cardiomyopathy. Any structural disease of the heart, whether it is VSD, whether it is PDA, whether it's tetralogy of Fallot, all congenital heart diseases are having chances of development of infective endocarditis. The exception is, as I told you, obviously atrial septal defect. The message is, if you're having a new onset murmur, that's one of the important diagnostic criteria for this condition. And let us now just summarize the important information that I have said. Let us assume that you are having a diagnosed case of rheumatic heart disease today, coming to your OPD with complaints of fever for past, let me say, 2 weeks or maybe 3 weeks, and he has been thoroughly investigated also. Like initially, when the fever came and fever was for only few days, he was tested for COVID-19. Then the patient was tested for obviously the standard infections like dengue, for example. So NS1 antigen was done, and the reports were turning out to be negative. So they thought, okay, it could be chikungunya, it could be malaria. So they did a chikungunya serology also. Then even for malaria, considering falciparum malaria, which is higher, having a higher incidence in our country, they did a dipstick, that is HRP2 dipstick. The point is that he is being gradually worked up for all the common reasons for development of fever, but unfortunately in this patient, all the reports are turning out to be negative. So they thought, okay, if it is not malaria, it is not chikungunya, it could be typhoid. So they did a Vidal also, maybe they did a blood culture also, and depending on whether it was early or a late presentation, but all the tests are turning out to be inconclusive. So they did a workup for tuberculosis as well. They even gave, saline nebulization to the patient to produce sputum. And then the sputum was evaluated by CBNAD. And well, the routine infections, which are so common in our country, ranging from COVID-19 to even tuberculosis, the workup of all of these has been done, and none of these infections are present. So the parents were also very worried, and they were carrying a file because rheumatic heart disease usually will be a child. And when you examined this child, on physical examination of the child, you actually noticed that the splenic tip was palpable. This was the clinical question that was given in the exam, where he mentioned a child having fever for a couple of weeks, splenic tip palpable, and the question said what will be the probable clinical diagnosis of this patient. So the query diagnosis of this patient would be infective endocarditis. As I said, if you are having a known case of heart disease, any structural heart disease, valvular heart disease, if he is having an unexplained fever, and simultaneously there is a splenomegaly present, that means that infective endocarditis process has already started in the patient. Let me just change the question now. Instead of talking about a child, it's a possibility that he might talk about an alcoholic. Whenever in cardiology, whenever you read alcoholic, the thought process of yours will always be dilated cardiomyopathy. Now, once you are going to be having a chronic alcoholic with dilated cardiomyopathy, having unexplained fever for past couple of weeks, and on examination the splenic tip is palpable, then again the clinical diagnosis should be thought in terms of infective endocarditis. The message is, guys, whenever he's going to give you a scenario of a pre-existing valvular lesion, structural heart disease present, and he gives you unexplained fever with a palpable spleen, that's a very good way to actually diagnose this condition. And rather, I would say that splenomegaly is not an early feature, it's a late feature. The disease process has not been identified till now. Ideally, it should be picked up relatively early, and our objective as doctors is to pick up the disease early. So in the subsequent slide, I'm going to explain to you what are the important diagnostic criteria and how are you going to pick up the disease relatively earlier. I shall now be explaining to you regarding modified Duke's criteria for diagnosis of infective endocarditis. We'll basically have a look at the major and the minor ones. And the surprising thing is that most of the clinical findings that I'm going to discuss before you, they are going to be included in the minor criteria. Now, this is totally different from what we study in Jones criteria, because in Jones, carditis, arthritis, all the clinical findings are the major ones. But here you will notice that the major ones are going to be investigations. And one of them that we are going to do is a echocardiography, both a transthoracic as well as a transesophageal echocardiography. The advantage of doing a transesophageal echocardiography would be to pick up vegetation, especially on the atrial side. So either he's going to give you the word vegetations. The only, I would say, downside is that vegetation size should be more than 2 millimeter for it to be visualized. So if the vegetation is smaller than the cutoff that I mentioned, then it may not be visualized and you can definitely miss the diagnosis. In some cases, however, the vegetations will cause substantial damage to the heart, substantial damage to the valve, and the end result of that would be that if the endocardial surface is damaged, then there could actually be activation of the local clotting process, and there could be even a thrombus formation that can embolize to distal circulation. So lots of time you might read the word oscillating intracardiac mass. The logic behind development of this would be the endocardial surface damage can actually trigger platelet activation and a local thrombus formation as well. It would be a bonus for you if he starts writing words like ring abscess or valve abscess, because then it obviously means an infective or a septic process occurring in a patient. But sometimes he might actually talk about a prostatic valve in place. Now, if a prostatic valve gets infected, then the term that he will use to describe this prostatic valve tissue, because the bacteria is proliferating on this biological tissue and destroying it. So you might read this word partial dehiscence of the prostatic valve. What I am highlighting here is that alternative terminologies. If he will write himself vegetations, if he will himself write ring abscess, valve abscess, then there's a distinct possibility that you will be anyway able to crack the question, and the examiner will not have any point in asking the question very well, because he has already given you the pointers. So instead of trying to remember the vegetation part, I would like you to remember terminologies like oscillating intracardiac mass, a dehiscence of the prostatic valve, and a perforation in the valve leaflet. Once we have done the echocardiography, both the types, that is transthoracic and transesophageal echocardiography, we are pretty sure that we are dealing with a defective process in the heart. In fact, in this image, what I have shown is a definitive mass. Now, obviously, this is not in 2-dimension, but I want to highlight that this mass per se is developing very close to the heart valve, and along with that, clinical history is obviously corroborating with that of infective endocarditis. Now, for diagnosing the organism per se, whichever is responsible, I will be doing a blood culture of this person. For blood culture, a lot of confusing information is given in the textbook, so I'll just try to simplify before you that what you are supposed to do is draw 3 samples of the patient from 3 different sites. You can be selecting like the left cubital fossa, right cubital fossa, and maybe the dorsum of the hand. And the point is that you obviously need to take proper hygienic issues, that is clean the skin properly with spirit, let it dry, then use betadine, then again clean with spirit. I mean, I want to reduce the contamination from the skin per se. Now you have to take 3 samples. So for example, you have taken 1 sample at 8 a.m. This sample you will transfer to 2 different culture bottles. So like you took a substantial amount of blood to be sufficient for 2 culture bottles, like 20 ml for example. Then at 10 a.m. in the morning, you are gonna draw another sample and transfer the sample equal into 2 culture bottles. And then at 12 in the noon, you are gonna do the same thing, draw a sample of the patient, divided equally into 2 culture bottles. Why are you doing this? Like what I have mentioned with a time lag of approximately 2 hours is basically because you want to demonstrate that the heart is pumping the bacteria into the systemic circulation, and sometimes it might be occurring intermittently. At the moment there is no pumping of bacteria maybe, and then after a few hours, once due to the shearing stress, the vegetations might start going into the systemic circulation. And obviously I want to increase the diagnostic yield also, because my technician may not plate the sample properly. So considering all the scenarios, they say ideally you should be taking 3 samples each at a 2-hour gap, and then at least out of these 3, 2 should be positive. You should be using different sites, you should be using proper hygiene to minimize the local bacterial contamination, and the report of blood culture will be at least 2 samples should be positive. And when I say 2 samples positive, what should be isolated is the typical microorganisms, and that is why I spoke about the organism based approach right away, because you obviously need to know what is the kind of organism or what is the name of the organism that you are anticipating to be presented. So that standard language given in the notes or standard information given in the textbook will be typical microorganisms isolated from at least 2. I've taken 3, but at least 2 separate cultures. And I would also like to add to this, I'm not writing my next statement. See, if I'm saying 2 positive, that 2 positive should be with the same organism. Like, it can't be that the first sample is showing Staph aureus and the second one is showing coliform. I mean, if it's going to be different organisms, then there could be mixing of the samples as well, and there's also possible contamination from the laboratory itself or some error on the part of the microbiologist. So he says that the 2 positive should be with the same microorganism itself. So 2 separate blood cultures are positive here, and therefore we can confirm the diagnosis. Now the query of a lot of doctors is that, sir, I have also read in Harrison that 2 cultures can be done 2 hours apart. Yeah, there are various ways. It can be 2 cultures 12 hours apart. Again, I am demonstrating no dissemination of bacteria by the heart. Maybe in the morning, by chance, the bacterial dissemination was not occurring. So in the evening, maybe bacterial dissemination will occur. But for a high diagnostic yield, this is what is recommended in the text matter in Harrison. The 3 samples should be taken at the following gaps at the time gaps which I have highlighted here. And he has also mentioned very categorically, and I want you to actually note this down, that the only scenario where he has given permission that suppose you have taken 3 samples and only 1 sample is turning out to be positive. If only 1 sample is positive, this relaxation in criteria is for 1 organism, Coxiella burnetii. Now, when I say that the query of most doctors is, sir, you did not talk about this one earlier. Yeah, I agree. I did not talk about this Q fever causing endocarditis earlier because I wanted to highlight at this specific juncture that ideally, at least from 3 samples, 2 samples should be turning out to be positive. That should be with the same typical microorganisms like Staph aureus in the first one, Staph aureus in the second one, or suppose second sample was turning out to be sterile due to whatever be the reason, the third one should again be having Staph aureus. The relaxation is, however, given for Q fever, which can contribute to development of endocarditis. And well, the query is then, how did Q fever come into the child or into an adult? Then I can say that this is a zoonotic infection. You see, in India, people will be keeping sheep in the house, goat in the house, maybe cattle in the house. So this is zoonotic infection coming into a person who is having a pre-existing heart disease. Like this is a child with rheumatic heart disease. He's living in rural India. Now in rural India, keeping animals in the house is a norm. So he has got the infection primarily from the animal. The infection went in obviously from the respiratory route, and then actually thus the hematogenous dissemination occurred, and it actually spread to the lungs of the child. But do remember this fact, this is an important one and has been asked in the exam, that for which organism, because this is not a routine typical organism, no. So that is why this exception has to be remembered at this juncture, because had I talked about this earlier, then I would not have actually been able to explain to you that only one culture is taken to be important here. Why? Because of the rarity of the infection. No, we need to increase our diagnostic yield. So sometimes we might have to cut down on our sensitivity as well. Now the point here is, I need to go in for echocardiography, I need to go in for a blood culture, and over and above this, additional point that I want you to remember from the major criteria domain will be development of a new onset murmur. I have explained this fact to you that a person of infective endocarditis can actually develop a perforation in the valve leaflet. This hole in the valve leaflet will be causing blood to move from a higher pressure chamber to a lower pressure chamber. So you can be having a development of a murmur. And this murmur will obviously depend upon which chamber is involved. Like suppose if I talk about aorta and left ventricle, it can be diastolic murmur. If I talk about left ventricle and left atria, that is mitral regurgitation, it will be a systolic murmur. So I'm not making a comment about whether it is going to be systolic and diastolic. Why? Because it would depend upon whichever valve is getting involved. If it is aortic valve, it will be a diastolic murmur. Where it's going to be mitral valve, it's going to be a systolic murmur. We will now focus on minor criteria for diagnosis of infective endocarditis, and they are relatively easier. One, I need to demonstrate presence of fever in the patient, obviously, because it's an infective process. The value of temperature should be more than 101 degree Fahrenheit at least. Ideally, you should be using a digital thermometer so that the hassle of misinterpretation by the nurse, etc., can be reduced, and you should demonstrate that on 2 separate occasions. Then there must be some predisposition in the patient. What I mean by predisposition is that if the question himself begins by saying IV drug user, or he talks about a person having a structural heart disease, valvular heart disease, then that would be considered as a predisposition. Now come immunological criteria. I'll try to explain the immunological criteria by using a mnemonic which goes by the name of ROG, that is ROG. Alphabet R would stand for Roth spots. Now, when I describe it, the usual query of most doctors is, Roth spots is such an important feature. Why is it included in the minor criteria? It should have been in the major one. Well, I want to tell you that they have deliberately put Roth spots in the minor criteria. Why? Because Roth spots can be seen even with respect to leukemia. Roth spots can be seen with respect to lymphoma. In fact, something as non-specific as anemia can also be having Roth spots. So you can see that Roth spots are not as specific as we are making them out to be. I agree to the fact that on the first read they look very, very specific on a fundus examination, but yes, because they're found in other conditions also, and in fact these other conditions are relatively more important causes of Roth spots as compared to infective endocarditis, which you're anyway familiar with. Alphabet O would stand for Osler nodes, on which the famous Osler residency in the United States is present. Well, the Osler nodes would be felt by you or checked out in the toes of the patient, that is the pulpy part of the tip of the finger. So either the tip of the finger or maybe the toes is where the Osler nodes can be palpated. They are P-shaped nodules that can be felt in the sites that I mentioned. Then would be glomerulonephritis. Now this is a highly neglected part, but they love to talk about it. Post-streptococcal glomerulonephritis, there was an infection in the heart valve, and then there is a immune complex mediated damage to even the kidney or the glomerulus, which causes PSGN, and that can contribute to hematuria. Now, when we are studying cardiology, when we are studying infective endocarditis, the last thing on our mind is glomerulonephritis. So this is definitely, I would say, less commonly seen, but at the same time important exam-wise. We will now focus on some vascular phenomenon or vascular aspects which are again important for diagnosis of infective endocarditis. The first one would be arterial emboli. As I highlighted that there is going to be literally a shower of septic foci into the systemic circulation. So all these arterial emboli will reach the brain circulation also. They will damage the wall of the brain blood vessels, contributing to aneurysm formation called as mycotic aneurysm. Can you tell me mycotic aneurysm will be caused by bacteria or will it be caused by fungus? I agree to the fact that the name is mycotic aneurysm, so the impression is it is going to be caused by fungus, but it's going to be caused by bacteria, no? Because we are talking about a bacterial dissemination. So the name mycotic aneurysm actually does not mean it's a fungus. It is actually Staph aureus mediated damage. And how did Staph aureus reach the brain blood vessel is primarily because of dissemination via the heart. And how did it reach the heart? That could be various ways, like this person maybe had a dental extraction, and post dental extraction, the dissemination of infection can definitely result in the heart valve getting colonized with this bacteria and then spread to the other parts of the body, or it could be IV drug use, as I explained earlier. So the vascular phenomenon will be arterial emboli. The sequelae of that is mycotic aneurysm. Then can be subrecurrent hemorrhage. So don't be surprised if he talks about nuchal rigidity developing in these patients. The infective emboli can even move from the right side of the heart. Like I was talking about IV drug users. So infection will come and damage tricuspid valve, but some will travel via the pulmonic valve into the lungs as well. So there could be septic pulmonic infarcts as well. There would be infection, there would be damage to the blood vessels of the lungs, resulting in pulmonary infarction. Then is an important feature from vascular phenomenon domain, which is to be remembered and is called as Janeway lesions. Well, they can just ask you Janeway lesions would be checked where, so that would be the palms of the person and soles of the patient. And what are they? They are just erythematous reddish macules. These are reddish erythematous macules. As I've zoomed in, as you can see in the thinner eminence of the patient, these erythematous macules can be visualized. So these are some of the important aspects that they love to ask about, especially the minor criteria. And when you read these names, no, lot of clinical names are there like rod spots, oscillor nodes, hematuria, aneurysm, subrecurrent hemorrhage. So the tendency is that we tend to think that this should be major, but because these can be seen in other, like hematuria can be seen in so many conditions, so they're deliberately been kept as a minor criteria per se. And over and above this additional aspect which I wanted to remember, the criteria mentioned are fever, predisposition, immunological criteria, vascular phenomenon. One more I'm gonna squeeze in, which is if a patient is having a positive blood culture but it is not meeting the major criteria. Like I had taught you that for typical organisms at least 2 should be positive, but due to some reason, it could be technical error on the part of the laboratory, maybe the person was given antibiotics and then the sample was drawn. There's a distinct possibility like this. Now the nurse came earlier than you, she gave antibiotic shot to the person and you took a sample after a few hours of the antibiotic shot. Then the culture might turn, the second culture report or third culture report might turn sterile because antibiotics have already been started in the patient on empirical grounds. So if positive blood culture is not meeting the major criteria, I have already explained to you that you will draw multiple samples in the patient from different site after taking proper hygiene. If blood culture is not meeting major criteria, the ones that are highlighted, then we will take that to be inclusive, or we'll take that to be in the minor criteria per se. And I would rather recommend you to remember minor criteria for this topic, because major is very simple. No, it's gonna be echo blood culture and a perforation in the valve leaflet. So I usually find people not making mistakes with respect to the major ones. Yeah, I have seen errors of judgment with respect to the minor ones. So they are very easy, guys. It's just that in a rush to remember all this information, sometimes I find people messing up between, like the question said, rod spots are found in, and there was no infective endocarditis in the option. So those people who had not listened carefully, they messed up with the MCQ, whereas this is a straightforward information. I mean, any physician would love to tell you that rod spots are something which are not only seen in infective endocarditis, but would be seen in other conditions as well, which is the reason why it has been included in minor. Otherwise, it should have been a major criteria if it was so specific for the disease process per se. I shall now be explaining to you regarding the diagnostic algorithm that we shall be using to identify infective endocarditis. Out of the criteria that I mentioned before you, this would be best if we can document at least two major criteria. Like, for example, blood culture is telling you that the organisms are present, and at the same time, echocardiography can tell you regarding the oscillating intracardiac mass or vegetations per se. But lots of time, person might have actually received empirical antibiotics before he came to you, and therefore the blood culture of the patient might turn out to be sterile. So in case you are able to document only one major criteria, like I gave a practical situation where already antibiotics have been administered to the patient, then the culture was sterile, only echocardiography was positive, then we need to take into consideration one major with three minor criteria, which are among the clinical ones that I highlighted. There is also a possibility that both echocardiography and blood culture might turn out to be negative. Why? Because size of vegetations is smaller than the resolution of the echocardiography. As a result of the limitations of the probe that we are using, you may not be able to pick up ultra small vegetations. As a result of it, the transthoracic and transesophageal echo report is negative, and because he had received empirical antibiotics, therefore culture is also sterile, and because I'm talking about smaller vegetation, so there cannot be a perforation present, so no new onset murmur. In those circumstances, we will have to rely only on the minor criteria. So how many should be positive? The answer is 5 minor criteria. This is a very simple algorithm, but slightly different from Jones criteria. So you need to be comfortable with it. And then I'm going to highlight regarding a term which can actually cause error of judgment in the exam, that is Duke score. Duke score is discussed with respect to treadmill test. It will actually help you evaluate the severity of chronic stable angina. I want to highlight this once again. When you are reading a question, lots of time there can be errors of judgment, because he can obviously be asking you a surgical aspect or Duke staging. You are very well comfortable with the fact that Duke staging is for carcinoma rectum, Duke scoring is for chronic stable angina, but when it comes to Duke's criteria, it is for infective endocarditis. Now we will study what are we going to do for these patients, that is empirical antibiotic therapy. So we can be starting the patient on penicillin G, and lots of time, because penicillin G will cause a very substantial amount of thrombophlebitis, so I can definitely use ampicillin also. I'm trying to give empirical treatment to my patient for covering both gram-positive and gram-negative organisms, and I'm writing plus minus if it is going to be IV drug abuser. So I know that Staph aureus can be one of the possibilities. So I will be giving methicillin, or based on, let me say, my microbiology department has already given me a notification that all the isolates of last year were MRSA, then we can use vancomycin, and depending upon the local reports per se, you can definitely be using even daptomycin if required. Now what I'm saying is that the most important step once the treatment has been started on empirical grounds is wait for culture sensitivity report, which might take about 72 hours to appear, because the culture sensitivity report will tell you the exact bacteria which is responsible, and will also tell you the antibiotics against which the organism is going to be susceptible or going to be resistant. So you can then select the best antibiotic for this particular person, and if you are after the culture sensitivity report giving appropriate antibiotics to this person, then this person should become afebrile in the next 7 days. In fact, how do I know my patient is responding to my treatment? Though I might have to give treatment for 2 weeks or maybe sometimes even more, the point is, if a person becomes afebrile by 7th day of starting the antibiotics, that is appropriate antibiotics. I repeat the fact once again. If I started, because initially I was giving empirical treatment, so the moment I start appropriate antibiotics, the organism is susceptible to it. So within 7 days of that, the person should become afebrile. Most patients become afebrile by 72 hours usually, and well, this is telling me that my patient is responding to my treatment. But let me say, hypothetically speaking, person is not responding. How would I know? The fever is still persisting, the spikes of fever are still present, maybe fever with chills and rigors is present, then there is a possibility that he could be having a valve abscess. In those circumstances, if he will develop a valve abscess, this is going to be a nightmare, because now there's going to be septic material in the heart valve, and that definitely can spread anywhere. In case of a valve abscess, we will require surgery, but I just want to here highlight usage of an antibiotic which is used in tuberculosis. Why rifampicin is being used here is because of the fact that it can go to those areas where other antibiotics cannot. My point is, antibiotics always go to that area wherever blood supply is present, but per se rifampicin can even diffuse into the tissue of the valve and can help you in reducing the valvular bacterial load. I'm not saying that it will cure the patient, but yeah, it will definitely be helpful in managing management of the patient, and definitive surgery would be required in these patients, and then subsequently a prostatic valve has to be deployed because it's a septic valve tissue that has to be excised, and a prostatic valve that has to be deployed. Lots of time things might become complicated because culture report turned out to be negative. Now, one of the reasons why culture report is negative is plain lethargy and casualness on the part of the laboratory technicians. You will see that half the time they don't want to work, so they will not put the sample appropriately, and as a result of it, the culture is turning out to be negative. If the culture turns out to be negative, I said first possibility is technical consideration. So since you had already foresighted this, or you thought that this could definitely happen, you personally called up the PGT1 microbiology and you said, buddy, I'm sending a sample of a suspected infective endocarditis patient, so please plate the sample yourself. Now, if a colleague of yours, a buddy of yours, a responsible doctor is going to be doing a proper plating of the culture sample, that it is unlikely that there could be any technical errors, then there's a distinct possibility that culture is still negative. Why? Because the organisms that are going to be growing inside the blood and then subsequently the heart valves are fastidious organisms. You see, fastidious organisms will have obviously more nutritional requirements, so they will not be growing on routine culture media like nutrient agar or blood agar. So I'm talking about here fastidious organisms, which are called as Haystack group of organisms, and mainly to broach on this topic, I highlighted this. I want to make it clear that if the culture report is negative, the first thought process of mine is some problem with the technical aspect. But if the technical aspect is sorted out, then you must take into consideration fastidious organisms as well. And Haystack group of organisms is again a microbiological detail. I'm sure you are aware of this, but still, just let me make you practice. Alphabet H would be standing for Haemophilus aprophyllus. When it comes to alphabet A, I get a lot of casual answers like Actinobacillus, etc. But if you read Harrison, he has mentioned for alphabet A, Aggregatibacter species. So I want you to follow what the textbook is saying. Then it becomes relatively easier for anybody to remember, because now the tongue-twisting name is relatively less. It is Cardiobacterium hominis. Then alphabet E is Echinella corrodens. A bit of tongue-twisting names, but once you have practiced them, then the chances of errors will obviously reduce. And for K, it would be Kingella, Kingele. These per se, the fastidious organisms, they are not gonna grow on the culture media, the traditional ones which are used. So you will definitely have to ask the microbiology department to step up and use special media, and they can also trouble you by asking you what antibiotics can be useful for management of Haystack group of organisms. So we use cephalosporins, that is third generation, and ceftriaxone will be useful for these patients. Apart from culture negative endocarditis, I also want you to be clear regarding what is referred as sterile vegetations in the heart. Like the best example I can give you of sterile vegetations in the heart would be Libman-Sachs endocarditis. In these patients, on the surface of the heart valves, it's only gonna be fibrin deposits. When I was describing infective endocarditis, I said millions and megatrillions of bacteria, but per se when it comes to Libman-Sachs endocarditis, then the aspect to be understood, aspect to be remembered will be that there would be sterile vegetations and they can involve any surface of the heart valve, but the speciality of Libman-Sachs endocarditis is that mainly the undersurface of the heart valve can be involved. Now, what is the importance of knowing the undersurface of the heart valve getting involved is because below the heart valve are gonna be chordae tendineae and they're gonna be attached to the papillary muscles. So if the undersurface is predominantly involved and damaged, because the structural support, when the valves will close, chordae tendineae will help in proper closure, and in you and me, not a single drop of blood is ever going to leak across the wall leaflets. But if chordae tendineae and papillary muscles are damaged, there can be leakage of blood. This leakage of blood or regurgitation per se will definitely cause problems, and therefore I'm describing a patient of Libman-Sachs endocarditis. This is a lady with SLE, and she's developed a chronic mitral regurgitation that will contribute to pansystolic murmur, and the MR component will also contribute to pulmonary edema. As a result of it, I definitely need to treat this patient, and the error of judgment of most of the people here is that whenever you are having a person with symptomatic mitral regurgitation, you are not going to treat it with steroids. I agree to the fact that the treatment of choice for SLE is steroids. But in Libman-Sachs endocarditis, if he's giving you a symptomatic patient of chronic metal regurgitation with pulmonary edema, steroids are not going to treat the pulmonary edema component. You will definitely have to go in for valve repair here, and therefore the question will deliberately ask you that in a person of Libman-Sachs endocarditis who's developed a valvular lesion, person is also having symptoms, what is the best treatment? Do not mark as steroids. I repeat the fact once again, yes, steroids are useful for exacerbations of SLE, but in valvular lesion, it is valve repair that would be recommended. Let's take one more such domain where you read the word sterile endocarditis. In fact, he will himself make it clear, NBTE, that is non-bacterial thrombotic endocarditis. This is taught in pathology also, so you can see overlap from microbiology, overlap from pathology also coming up. Non-bacterial thrombotic endocarditis, or NBTE. That's the term I want you to remember, that is meranteric endocarditis. And while I'm writing it, guys, this is a question for you guys. Can you tell me the etiology behind it? Well, obviously the name is very clear. There's no infection present. So thrombotic endocarditis, why would the vegetations be developing in this case? Well, the speciality of non-bacterial thrombotic endocarditis is association with acute promyelocytic leukemia. Yes, guys, it's going to be associated with blood cancer, the same one that you study as T15 to 17 translocation. This is the one which can even cause DIC, and we use ATRA for management of this condition. Acute promyelocytic leukemia can be responsible for NBTE, so you can very well understand blood cancer associated endocarditis. Apart from this, obviously it can be ovarian cancer, it is GI cancer, but because of special, M3 importance, I will just say that it gives more leverage for the examiner to ask you, because he can incorporate details of M3 also. So acute promyelocytic leukemia per se is responsible for development of non-bacterial thrombotic endocarditis, and the reason why we are studying these two topics is because of the following reasons. Please look at this very carefully, though it might look like a crude representation of the valve leaflets per se, but this definitely will give a rather edge to your preparation. You see, in Libman-Sachs endocarditis, the vegetations can involve any surface, but under surface of the heart valve involvement is of paramount importance, because that's where the quadrate tendinitis and papillary muscle attachments are. But when it comes to non-bacterial thrombotic endocarditis, the involvement will be on the lateral surface of the valve leaflets, is where the vegetations are going to be present. Obviously, they are sterile vegetations. They are only having fibrin, and there are absolutely no bacteria present here. Let me do this representation once again. We can take this as representation of a valve leaflet. I am here showing Ashkoff nodules on the superior surface, inferior surface of the valve leaflet, but high concentration of Ashkoff nodules at the tip of the valves per se. The technical term that you will read lots of time pathologists speaking about, especially when they talk about rheumatic endocarditis, because in rheumatic you have Ashkoff nodules, they don't have any bacteria. So even when you study the topic of rheumatic endocarditis, the rheumatic fever I've discussed separately in the lecture prior to this, I have highlighted that part or this particular domain even there in rheumatic carditis, but I just want to reiterate the fact that there can be valvulitis, there can be commissural and involvement in rheumatic heart disease, and because of this there can definitely be leakage of blood across the valve leaflets, and this blood that is leaking will also contribute to characteristic murmur. The characteristic murmur of rheumatic etiology is what is referred to as Caricum's murmur. So I want you to remember, and the technical aspects of Caricum murmur have also been highlighted, that this is a mid-diastolic murmur as per Harrison. Pediatric books might mention late diastolic murmur as well, but first answer would definitely depend on the options. Early versus mid, it is a mid-diastolic murmur. I have today given you 3 examples of sterile endocarditis. The 3 examples of sterile endocarditis are Libman-Sachs endocarditis, non-bacterial thrombotic endocarditis, and then obviously the rheumatic etiology. So let us just quickly summarize the salient features for the sterile endocarditis component here as well. I am gonna speak a little faster now. I'm gonna talk about only fibrin deposits on the heart valves, that is sterile vegetations present. I have spoken regarding Libman-Sachs. NBTE is meranteric endocarditis, the one associated with malignancy, and then is rheumatic endocarditis. The reason why you are being made to practice this is because when it comes to Libman-Sachs, the association is with SLE. Any surface can be involved, but under surface involvement is going to result in valvular lesions. In NBTE per se, it is going to be association with M3 variety of acute myeloid leukemia, and I highlighted that the vegetations could be along the lines of closure. When it comes to rheumatic, we will casually use the word valvulitis, but the point is these Ashcroft nodules are mainly causing development of a murmur as well, and the term used is commiserolents. So these are some of the important terminologies. You have read them even in pathology. So I don't think so there is absolutely any issues with respect to involving or studying about these facts once again. And at the same time, I just want to highlight that if somebody is having a valvular lesion in the heart and the person is having a dental procedure, then even antibiotic prophylaxis should be given. So on my next slide, I'm going to explain to you regarding when would you be giving antibiotic prophylaxis. I mean, which valvular conditions or which heart conditions per se is where antibiotic prophylaxis is required. We do not require antibiotic prophylaxis for GI procedures like endoscopy or genitourinary procedures like a cystoscopy. But yeah, dental extraction per se, because of colonization, oral cavity will anyway be having bacteria. They can be seeding of the heart valves, and already if the heart valve is damaged, the chances increase even further of worsening of the lesion. That is why in the next slide we are going to talk about antibiotic prophylaxis for the patient. I've subdivided the discussion into three parts or three domains. One is going to be the infective component, then I've talked about sterile components, and lastly I'm talking about the prophylaxis component as well. Now let us assume that a person is having a cardiac lesion and is having a requirement of dental procedure. So when will I say that this cardiac lesion per se is high risk before the person undergoes a dental extraction per se? Would be any person who's had already a prosthetic valve deployed. The choice of antibiotic can vary with the, I would say, the convenience of the physician. Like lots of time you will see physicians using amoxicillin and azithromycin. Obviously, azithromycin will be relatively more comfortable because of lesser incidence of diarrhea. Amoxicillin, the dose used is usually 2 grams at least 1 hour before the procedure. Amoxicillin would be standard 500 milligram tablet, again 1 hour before the procedure. If a person has already suffered from endocarditis episode earlier, then yes, it makes sense to give antibiotic prophylaxis. For the third point, I want you to remember that this patient is having an unrepaired congenital cyanotic heart disease. By double CHD, I mean a congenital cyanotic heart disease like tetralogy Fallot. In TOF, again, there's a ejection systolic murmur. That means there's a pressure gradient, and wherever there is a pressure gradient, the incidence of infection is also present. I want you to remember that even in patients who are having a completely repaired cyanotic congenital heart disease. Now the query of most doctors is, sir, unrepaired, understandable. Why incompletely repaired? My point is that even if you have repaired the congenital cyanotic heart disease or you have done a palliative procedure in the patient, still in the first 6 months, I want you to highlight and remember this statement, unrepaired will obviously require antibiotic prophylaxis. Even when you have completely repaired, in the first 6 months of surgery, the risk is very much there. Then obviously as you go down the line or continue with the lifespan of the person, the incidence of this antibiotic prophylaxis requirement will gradually go down. So message is cyanotic heart disease, unrepaired and repaired, both will require. In repaired one, it will be the first 6 months. Then would be incomplete repair of congenital cyanotic heart disease. Like for example, you did not do a complete repair in a sense that only blaloctosic shunt was done. If you're doing a blaloctosic shunt, only you are hooking up the subclavian artery to the pulmonary artery. So that's a palliative procedure. So it is incomplete repair. So do remember these minor aberrations that I'm highlighting before you. And then the last aspect would be a person who's undergone a cardiac transplantation and is now having problem with the heart valves of the new heart that he has got. So I'm writing the word valvulopathy after a cardiac transplantation. Like this guy was a patient of dilated cardiomyopathy, underwent a transplantation. Now in the new heart there is a valvular region developing. The antibiotics I mentioned already, that is amoxicillin and azithromycin, and this is usually required 1 hour before the procedure. Either of the two can be given. As I said, amoxicillin 2 grams or azithromycin 500 milligram. However, please remember the fact that we do not require antibiotic prophylaxis for patients of high risk cardiac lesions who are undergoing any kind of GI or GU, that is genitourinary procedures per se. The person could be undergoing an endoscopy, he could be undergoing maybe a cystoscopy for any genitourinary complaints. If he is undergoing any of these procedures, then there is no need for antibiotic prophylaxis but is required with dental procedures. In 3 of the options you can notice congenital cyanotic heart disease has come up. So yes, do remember that we definitely will be having a high incidence of infective endocarditis with left to right sided shunts because they're anyway gonna be per se high pressure gradient lesions. But if they are treated then there is obviously no need of antibiotic procedure. But in cyanotic heart disease, even if you repair, because most of the procedures that are done in cyanotic heart disease are palliative procedures, in a sense that you are doing a blalotoxic shunting or pod shunting or other various types of shunts that you study in pediatrics. So because the pressure gradient may still be present in the heart, so it makes sense to give antibiotic prophylaxis to the patient. These are some details that I would like you to remember for this topic. And most importantly, I would like to highlight on the diagnostic criteria, which are very simple, but lots of time I've seen people messing up on the minor ones, so they are the ones to be given priority. And well, keep hammering, guys, keep learning new facts, and you shall come out with bright flying colors.